the reality of the persistence and the compliance of warfarin therapy in atrial fibrillation. This is my disclosure. So I will talk about the challenge with vitamin K antagonist persistence in atrial fibrillation. And I will talk about vitamin K antagonist persistence in randomized clinical trial. And I also talk about the VKA persistence in real-world study, review of one-year GARFIELD data. And I will talk about review of persistence with direct oral anticoagulant. Will these new treatment resolve the issue of the persistence? It's a important question, and I will draw conclusion. Challenge with vitamin K antagonist impact adherence and persistence of atrial fibrillation. Everybody already speaks. Only 50 to 60% of eligible AF patients receive vitamin K antagonist. Poor INR control has been shown amongst patients who receive vitamin K antagonist. Regular monitoring is burdensome. Patients treated with vitamin K antagonist are at risk of hemorrhage, that everybody knows. Poor persistence also add to the underutilization. That's the point I would like to share with you. Why physicians withhold vitamin K antagonist in patients at risk of stroke? This is the lesson from GARFIELD Registry. So you are a physician, if you are a physician, why you are not using vitamin K antagonist, even though they are effective in prevention of stroke? So the majority of the reason is physician's choice, 48.3%, even though those patients are more than CHAS score 2. It's really high-risk patient. So that 48% of the patient didn't receive vitamin K antagonist due to physician's choice. If you look carefully about the reason, some of the reason is very interesting. Like some of the physician, does not use vitamin K antagonist, even though CHAS score is 2 based upon guideline recommendation. This is interesting. So VKA persistence, lesson from randomized trial. So VKA persistence range from 75 to 79% at 1 year. Permanent discontinuation rate for warfarin is 22% in Rocket AF study, 28% in Aristotle study. I came from Japan, so I would like to share with you our special trial, that is J-Rocket. So, we know adverse event-related discontinuation rate in warfarin patient is 15% from the database of the J-Rocket. So 70% of warfarin stopped due to adverse event in Japanese sub-analysis of the Aristotle. So the real-world study, VK persistence in atrial fibrillation, historical data demonstrated discontinuation rate range from 26 to 43% during the first year of therapy. Recent data, 32% discontinuation at 1 year, 43% at 2 years, 61% within 5 years. So warfarin is a difficult drug. So GARFIELD patient initiating vitamin K antagonist therapy at atrial fibrillation diagnosis. This is the baseline characteristics. 53.4% of the patient initiated vitamin K antagonist therapy at time of diagnosis. Those are baseline characteristics of those patients. So the CHAS-2 score is approximately 2 to 2.0, CHAS-BASC score 3.3, Hasbred score 1.1. So those are typical atrial fibrillation patients. So this is the data I would like to emphasize. This is important data GARFIELD Registry demonstrated. So patient initiating vitamin K antagonist therapy at time of atrial fibrillation diagnosis, if we have to discontinue vitamin K therapy within 4 months, the death rate of the patient within 1 year is more than 20%, 23.5%. So, you know, as Professor Haas demonstrated, if we can treat patient nicely with warfarin, it is good. But if, you know, we have to stop warfarin, those patients have a very poor outcome. That is also true for stroke and systemic embolism. If we have to stop warfarin within 4 months, 1 year rate of stroke and systemic emboli is 3.0%. And that is also true for major bleeding. If we have to stop warfarin within 4 months, 1 year event rate of serious bleeding is 3.8%. So warfarin is relatively difficult drug. So persistence of vitamin K antagonist and direct oral anticoagulant. This is not the data from GARFIELD. This is the data from claim data from U.S. Department of Defense. So overall median persistent rate of dabigatran is 389 days. It's longer than the overall median persistent rate of warfarin, 135 days. Persistent rate at follow-up are higher for dabigatran. At 6 months, 64% versus 50% with warfarin. 1 year, 41% and 24%. Patients started on dabigatran more persistent than patients who began warfarin treatment. For both groups, patients with a low risk of stroke were more likely to discontinue therapy. So as a physician, we have to take care of the patient for long-term periods. So we have to consider about the discontinuation and persistence and compliance of the warfarin therapy. So VKA discontinuation is common in atrial fibrillation patients at risk of stroke. Physician and patient preference are major contributor, especially for the physician preference to discontinuation of VKA therapy. Suboptimal persistence highlights the need for improved management of patients with atrial fibrillation. So direct oral anticoagulant may offer improved compliance and potentially better outcome, especially in VK intolerant patients. You know, as Professor Keika and Professor Haas demonstrated, warfarin is nice drug if we can control warfarin in a good way. But, you know, if we cannot control in a, you know, better way, warfarin is not a good drug. Cost of direct oral anticoagulant may be prohibitive in some developing countries. So physicians should therefore focus on educating patients on vitamin K antagonist therapy. Thank you very much for ladies and gentlemen. Thank you.
Thank you, Professor Goto. Now, we move from some of the insights to what we might learn from another area where there has been resistance to the introduction and effective broad use of anticoagulation to prevent thrombosis, and that's in the venous circulation with venous thromboembolism. And Professor Sam Goldhaber from